Hey everyone, and welcome to The Explainer. Today, we're going to look at health disparities a bit differently. We aren't just looking at them as, unfortunate statistics. Instead, we're going to view them as the direct, observable outputs of an invisible engine. We're breaking down a really fascinating piece of research by Michele that actually decodes the mechanics of how societal systems create, and more importantly, sustain gaps in healthcare. It's a totally different way to look at the issue, so let's jump in and see how this systems-level analysis reframes the whole conversation.
Here is our roadmap for today. We'll start with the healthcare equity gap, then unpack LGBTQ+ care to give us a grounded example. From there, we'll examine the engine of marginalization, dive into a tale of two systems, and finally wrap up with rewiring health policy.
All right, part one, the healthcare equity gap. So why do some health disparities just refuse to go away? Seriously, despite all our new medical technologies and constantly changing policies, we still see these distinct health struggles stubbornly tied to certain populations. Battlefisher points out a really crucial starting point here. A disparity is measurable specifically because we can compare it to a reference group that isn't under-resourced. Essentially, we know the gap exists because we can literally see one group thriving right next to a marginalized group that is struggling. So the big puzzle for us today is, what exactly locks that gap in place?
Now, what's really interesting about this slide is just how interconnected and frankly overwhelming this systemic map of macro-level effects really is. It's like a giant tangled web. You've got nodes for social determinants, implicit biases, minority stress, intersecting identities, and they're all pointing toward and influencing health outcomes. It proves that disparity isn't just one bad policy or one doctor making a mistake. It's a vast mechanical web of feedback loops. But don't worry, we are going to untangle this step by step.
Moving right along to Section 2, Unpacking LGBTQ+ care.
To really understand this invisible engine, it helps to zoom in on a specific example. When we look at the clinical data for LGBTQ+ breast and chest care, the disparity is glaring. LGBTQ+ patients face disproportionately poor health outcomes, and historically, they have much lower rates of actually utilizing preventive care when you compare them to those resource reference groups we just talked about. It's a very tangible, measurable gap in equity, and when a systems thinker sees a gap like this, they immediately ask, what are the specific inputs causing this output?
Well, the research from McGlynn and colleagues identifies two specific clinical assumptions that basically act as the gears creating this care gap. First, there's a presumption that heterosexual, cisgender, and non-intersex identities are just the default for patients. Second, there's an assumption that LGBTQ+ patients don't have medical problems that warrant culturally affirming clinical attention. And guys, these aren't just passing thoughts. They are structural presumptions built right into intake forms, provider interactions, and insurance policies. They literally sustain inadequate care by design.
Which brings us to Section 3, the engine of marginalization. Let's pop the hood on this machine.
We hear the word marginalization thrown around a lot, right? But let's actually define it precisely using research from Hall and colleagues. They define it as a process through which persons are peripheralized based on their identities, associations, experiences, and environments. I really want you to notice the word process there. Marginalization isn't just a static state of being. It's an active, othering mechanism. It is quite literally an engine that physically and systemically pushes people to the periphery, which limits their access to services and builds this deep, justified mistrust in the healthcare system itself. And what powers that process? We have these concepts called attractors. Drawing on Strawn's work in systems theory, attractors are the deep structural beliefs used to validate a system's behavior. They shape and stabilize a system's possible states. You can kind of think of attractors as an invisible gravity, the deep-seated societal beliefs that keep these health disparities firmly locked in place. When you look at it this way, it makes total sense why pulling a marginalized group toward equity is so incredibly difficult. The system is literally designed to resist that change.
Okay, let's dive into this. Section 4, a tale of two systems.
If we look at these two realities side by side, the contrast is pretty wild. On one hand, you have the health-restricting subsystem. This is populated by under-resourced people with limited social capital, which makes poor health outcomes highly probable. Right next door, operating at the exact same time, is the health-flourishing subsystem. This involves resourced people with high access to capital, making optimal health probable. The craziest part about this? Both systems operate mechanically the exact same way. They adapt, they use feedback loops, but because of their starting resources, they produce completely opposite effects.
Let's look a little closer at how these two systems actually maintain themselves, starting with boundary mechanisms. The restricting system uses social stratification and peripheralization to build walls. It creates friction. It keeps people out. Meanwhile, the flourishing system operates on unfettered access to health-supporting info and basically non-restricted health autonomy. One system acts as a rigid gatekeeper and the other acts as a wide-open door.
Then we have agent agency, which is basically how much control an individual actually has over the machine. In the restricting subsystem, a person has suboptimal agency. Their influence to get the system to work in their favor is highly, highly restricted. But over in the flourishing subsystem, individuals have nearly unlimited influence to navigate the space, advocate for themselves, and pull levers to their advantage. The machine bends to their will.
Finally, we see this heavily skewed resource distribution. One system concentrates disadvantageous social relationships, meaning a lack of resources just continually compounds on itself. The other system concentrates and hoards advantageous relationships, and this creates an incredibly durable feedback loop. For one group, the status quo sustains active social disadvantage. For the other, it supports a durable advantage. It really is a dual engine operating in perfect unequal harmony.
All right, Section 5, Rewiring Health Policy. Let's talk about how to fix it.
So, the crucial point is this: systems equate to change. Because these are adaptive mechanical systems, they are absolutely not invincible. In fact, the system supporting disparity actually has a lot of difficulty balancing when there are fluctuations in its equilibrium. It's vulnerable. This means that if public health policy introduces the right kind of targeted change, if we disrupt those negative attractors and those strict boundary mechanisms, we can actually destabilize the machine that creates the inequity and force it to adapt toward fairness. There is a quote from the source text that absolutely nails this. It says, "The system's mechanism is not to blame, as it acts mechanically. However, the social implications of the system's behavior are crucial to addressing health disparities." It's such a profound point. The engine itself doesn't have morals. It's just turning the gears it was built with. But we, as a society, are responsible for the social implications it produces. We literally have the power and the obligation to rewrite the rules of the machine.
Which leaves us with this final, provocative question to consider. How can systems thinking change the way we address health inequities right in our own communities? When you stop looking at isolated health stats and start actually seeing the attractors, the feedback loops, and the boundary mechanisms operating all around you, how does that change your approach to advocating for better health policy? I really hope this breakdown gave you a powerful new lens to see the invisible structures shaping our world. Thanks for hanging out and diving into the explainer with me today, and keep questioning the systems around you.